Welcome, everyone. Thank you for joining us for today's presentation titled Flotetuzumab, an investigational CD123, CD3 Bispecific DART protein-induced clustering of both CD3 positive T cells and CD123 positive AML cells in bone marrow biopsies, and the association of this drug with response to treatment in primary relapse acute myeloid leukemia patients. It is my pleasure to introduce to you Professor Jan Davidson. Professor Davidson is the Director of Clinical Development and Research at Macrogenics Company. For a complete biography on our speaker, please visit the tab at the top of your screen. In addition, if you have any questions during his presentation, we encourage you to submit these questions in the Q&A box. The speaker will get back to you, will respond you by email. So without further delay, please join me in welcome Dr. Davidson. I will now turn the presentation to him.
Hello, my name is Jan Davidson from Macrogenics. I wanted to thank NanoString for inviting me to participate in this conference, Advancing Science in Oncology. I will be presenting today our work on Flotetuzumab, which is an investigational CD123 by CD3 bispecific DART protein, which is being currently developed as salvage immunotherapy for refractory acute AML. Acute myeloid leukemia is a highly heterogeneous disease. Despite recent introduction of several new therapies, AML remains very difficult to treat, with many patients being either refractory to current available therapeutics or relapsing shortly thereafter. The treatment paradigm has not changed significantly in many decades, with patients being stratified by their ability to tolerate high-dose cytotoxic chemotherapy. Lots of these patients that are refractory or relapse shortly thereafter are usually treated as a single clinical entity. However, it is now well recognized that these patients differ not only in their success of subsequent salvage therapies, but also in some of their immunological phenotypes. These patients with primary induction failure or early relapse are usually recommended to undergo further clinical or to be involved in further clinical studies, and there's really not any real approved therapy for those patients. Flotetuzumab is a bispecific antibody-based molecule to CD3 epsilon and CD123 engineered in a DART format. CD123 is a low-affinity interleukin-3 receptor. Alpha is expressed in about 60 to 80% of patients with AML. What makes CD123 particularly appealing as a therapeutic target in AML is not only that it's highly expressed, its high expression in AML blasts, but it's also associated with poor outcomes. Furthermore, CD123 is also putatively expressed in AML progenitor and stem cells. CD3 engaging bispecific molecules like Flotetuzumab bind both the tumor and the effector cells to promote an immunological synapse and redirect polyclonal effector tumor to kill tumor cells in an MHC-independent fashion. So essentially, theoretically, Flotetuzumab is a prodrug, and the active moiety of the reaction is the T cell. Flotetuzumab engages T cells in the context of CD123 AML blast, which leads to T cell activation, expansion, and differentiation. Cytokine release ensues as part of the T cell function, which leads to AML blast killing. Due to the mode of action of T cell uncoupling killing activity and cytokine release, which is an unexpected, as expected but unwanted side effect, is challenging. And I will speak a little bit more to that further on in the talk. In this slide, what we see is the example of flotetuzumab activity. This is a bone marrow biopsy taken from a patient treated on flotetuzumab. On the left-hand side of the panel, you see the baseline biopsy with CD3 stained in yellow, CD123 stained in red, and DAPI. What is very interesting to see is that upon treatment with flotetuzumab, the patient develops very nice T-cell clusters surrounding CD123 positive cells, or AML blasts. In this highlight section, what you see is a very nice interaction of a CD3 cell with a CD123 AML blast, which occurs in the context of flotetuzumab administration. The next slide. This slide, what we see is using GeoMx DSP multiplexed quantification of 50 plus IO proteins also allowed us to get further insights into the CD3 clusters. We initially selected geometric regions of interest covering the whole tissue, and then compared protein expressions between the ROIs with and without T-cell clustering. What was very interesting is that these T-cell clusters showed markers of T-cell activation, namely CD27, CD44, and CD45-RO, as well as negative immune checkpoints with higher expression of PDL2, CTLA4, and ICOS. Moreover, we also analyzed match-based samples, pre and post samples using the pan-cancer IO assay. And we found that treatment with flotetuzumab modulated the tumor microenvironment. Flotetuzumab was associated with an increase in TIS scores, antigen processing machinery, and interferon gamma scores, as well as PD-L1 expression. The latter finding was also confirmed at the protein level in one patient with evidence of anti-leukemic activity of flotetuzumab using GeoMx digital spatial profiling platform for the highly multiplex quantification of these proteins. The volcano plot in panel C shows how PD-L1 expression, as well as other interferon-inducible proteins, including STING, was significantly upregulated in post-cycle 1 flotetuzumab. So in conclusion from this section, what we see is that flotetuzumab, the mode of action of flotetuzumab, which is involving T cells in the context of AML blast, leads to activation, proliferation, and AML lysis by T cell activity. Next, I'll talk a little bit about the clinical study and how we and some of the correlative work that we've done within that study. So this is a clinical study. It's a phase 1/2 first-in-human dose escalation study of flotetuzumab, the bispecific protein in patients with relapse of refractory AML. The study's been designed in 2 phases, a dose escalation phase, which has been completed and has defined the maximum tolerated dose and the recommended phase 2 dose to be 500 nanograms per kilogram per day in a continuous infusion. The study, in the inclusion criteria, included refractory AML, which is defined as patients that are refractory to 2 induction attempts, or first relapse with an initial CR duration of less than 6 months, or HMA failure of greater than 4 cycles. Relapse AML was defined as initial response rate lasting more than 6 months. Prior history of hematopoietic stem cell transplant was exclusionary, and what we will do is we'll present the data of the first 50 patients treated at the recommended phase 2 dose. This table highlights the overall demographics of the patients, the 50 patients treated at the recommended phase 2 dose. What we see is that 60% of the patients treated at the recommended phase 2 dose met the criteria of refractory disease, that is primary induction failure and early relapse. The majority of the patients had adverse risk criteria based on the ELN 2017 criteria, and 36% of these patients had secondary AML. These patients were all heavily pretreated with a median prior lines of therapy of 3 lines of therapy, but ranging between 1 and 9 prior lines of therapy. So overall, collectively, these patients represent a very poor risk population with few effective treatments and otherwise limited life expectancy. The overall safety analysis identified infusion-related reactions and cytokine release syndrome as a dominant adverse event for flotetuzumab, which is expected based on the mode of action of flotetuzumab. Of the patients with IRR-CRS, the majority had mild to moderate signs and symptoms, with only 4% experiencing a single grade 3 event. No grade 4 or 5 IRR-CRS events were recorded. Other non-IRR-CRS treatment-related grade 3 events were less common. So what we've learned so far is that more CRS events, IRR-CRS events, occurred in the first week of treatment and gradually decreased with continuous dosing. So IRR-CRS seems to be a first dose event and not necessarily a Cmax event. Most events occurred in the first 48 to 72 hours and decreased thereafter. The incidence of decreased each week during continuous dosing at the maximum tolerated dose. There's an increase in incidence of events were noted upon the dose interruptions. So one of the things that we emphasize is to try to maintain continuous dosing of flotetuzumab to try to minimize cytokine release syndrome. What we did find an association between anti-leukemic activity and incidence of IRR-CRS. There's no such association noted with IRR-CRS severity, which is highlighted on the graph on the right. However, what we do see is that with the number of IRR-CRS events or days of CRS events during treatment corresponds with a greater decrease in bone marrow blasts in the bone marrow. So consequently, reducing the severity of IRR-CRS did not appear to preclude flotetuzumab's anti-leukemic activity, and the goal on the study has been more to blunt rather than to eliminate IRR-CRS. So on the study, we have implemented several mitigating strategies to try to control CRS. The first thing that we have implemented is prompt use of tosilismab. The impact of tosilismab and flotetuzumab-induced IRR-CRS is noted on the left-hand side by the higher levels of IL-6 in patients that have received tosilismab. Tosilismab is an IL-6 receptor blocker, and hence, upon administration of tosilismab, there's a higher level of circulating IL-6 in the blood. And this is anticipated, so hence the greater level of IL-6 in the patients after dosing with tosilismab is anticipating giving the drug's mode of action. On the right-hand side, we see the prompt tosilismab usage was associated with a decreased duration of IRR-CRS events, with an average of 1.8 days versus 1.2 days in patients that had not and had been administered tosilismab. The second mitigating strategy that we've implemented is a sequential increment of leading dose in cycle 1, in week 1 of cycle 1. What you see here is upon administration, the study when first designed was administered flotetuzumab initially at 100 nanograms per kilogram per day for week 1, thereafter stepping up the dose to 500 nanograms per kilogram per day 1. In the middle graph, you see the incidence and severity of CRS after the 1-step leading dose. And then after that, we implemented a lower step up dosing at 30 nanograms per kilogram per day before going up to 100 nanograms per kilogram per day and then stepping up to 500 nanograms per kilogram per day. What that did was it did reduce the severity of CRS in week 1, as well as week 3 and week 4, highlighted by the blue line in the middle graph. However, that was still suboptimal, and that is noted by the low dose intensity that is seen on the right-hand graph, with a dose intensity of 59% of intended dose. We next included more steps in the step-up dosing in week 1, so a more gradual multi-step leading dose. And what that did is overall reduce the severity and incidence of RR-CRS, notably in weeks 2, 3, and 4. And that is also reflected in the much higher dose intensity that we see upon introduction of the multiple leading dose. So from 50% to about 80% dose intensity. By implementing those two strategies, we have managed to maintain CRS at a very low grade of grade 1 and 2. Here you see of all the events that were documented in this cohort of patients, most of the events were grade 1, 57% of the events were grade 1, 42% were grade 2, and less than 1% of the events were grade 3. Also notably, CRS events are of short duration, with grade 1 events lasting a median of 1 day, grade 2 lasting a median of 2 days, and the only grade 3 event documented in this cohort of patients lasting 3 days. However, the event peaks at grade 3 during these 72 hours, but doesn't really, the patient is not in grade 3 severity for that duration. So now we'll focus on Flotetuzumab activity at the recommended phase 2 dose. What we see, this waterfall plot shows the 50 patients treated at the recommended phase 2 dose. 45 of those patients are evaluable. 5 patients progressed on peripheral blood blasts and hence did not reflect it in the waterfall plot. 39 patients are on the waterfall plot. The on-study complete remission rate is 13.3% with a CR/CRh rate of 20% and a complete response rate of 22.2%. One of the things that we've been very interested is in identifying the target population, hence as not to overtreat patients that would be unresponsive to Flotetuzumab and focus more on the patients on the right-hand side of the waterfall plot that would be the responsive patients. So one of the things that we know, we've learned is that 40 to 50% of patients with newly diagnosed AML fail to achieve a complete remission or complete response with intensive induction therapy. These we name, namely primary induction failure patients. And experience disease recurrence after a short remission rate. Those are early relapse patients. And looking at the literature, we note that these patients, the probability of these patients responding to salvage chemotherapy is very low, and hence, usually the recommendation for these patients is to be treated on clinical study. What is interesting about these patients is that primary induction failure or poor prognosis has been associated with increased immune infiltration in the tumor microenvironment and high CD123 expression on AML blasts. So we were interested in trying to explore these two notions. This is work. This slide summarizes work of Sergio Rutella, who is also a presenter at this conference and a close collaborator. And what he did is in the discovery of 62 patients with newly diagnosed AML, treated with curative intent on a cytarabine-based chemotherapy backbone. What is noted here is a supervised hierarchical clustering of a correlative matrix identifying 3 distinct immune gene expression profiles in the bone marrow tumor microenvironment. And what you see here is namely innate, adaptive, and exhausted gene expression profiles. So what we did is we explored the immune gene signatures in de novo AML patients that were treated with curative intent, as I mentioned before. And what was interesting about that is that these patients clustered into 2 separate immune clusters, namely an immune-infiltrated cluster and an immune-depleted cluster. What was interesting about this was that based on the fact that there was clinical outcome data available, what we see here is that patients with an immune-infiltrated cluster did not respond as well to cytotoxic chemotherapy as patients with immune-depleted tumor microenvironment. And interesting, these immune scores were better predictors of chemotherapy resistance in the AML discovery cohort than the ELN cytogenetic risk classifiers, with areas under the curve and values of 0.815 compared to 0.702 for the ELN risk category. And these findings were further validated in silico using transcriptomic data from the BEAT AML master trial, which is shown in panel B. So what we next did is we interrogated patients that were treated on the Flotetuzumab study in a similar way using the pan-cancer IO360 panel. And what we see here on the right, on the left-hand block, is that these immune signatures segregate the patients treated with Flotetuzumab into two clusters. Again, clusters that was immune-infiltrated as well as immune-depleted at baseline. And what we notice is that patients with refractory disease had a higher level of immune interferon gamma scores, as well as inflamed chemokines, TIS scores, and interferon downstream score related in relation to patients with relapse disease. Also, when we look at these patients in relation to patients that had anti-leukemic activity, defined by a decrease of more than 30% of bone marrow blasts compared to non-responders, patients that showed evidence of Flotetuzumab anti-leukemic activity also had higher levels of interferon gamma module score, as well as a TIS score. And these were good predictors of response to Flotetuzumab, as shown in the areas under at the AU rocks of 0.806 and 0.847. So overall, what we see is that as opposed to being predictive of cytotoxic resistance, AML patients with high immune infiltration were very susceptible to response to Flotetuzumab, as you can see here, with a higher complete response rate of 41.2% versus 7.7% in immune-depleted patients. And comparing areas under the curve, the interferon dominant signature in AML was not only very predictive of chemoresistance with an AU ROC of 0.92, but also very predictive of Flotetuzumab anti-leukemic activity with an AU ROC of 0.85. So if we now go back to our waterfall plot and we overlay, in that waterfall plot, overlay the AML status on coming onto the Flotetuzumab study as primary induction failure, early relapse, late relapse, or HMA failure, what we see is that the patients that are responding to Flotetuzumab are the patients with primary induction failure disease and early relapse. So what we've now tried to do is define that population as the population that is sensitive to Flotetuzumab. That specific population, the complete remission rate is nearly 18% for the evaluable patients, with a CR/CRh rate of 28.6 and a complete response rate of 32.1. Interestingly, meta-analysis of published data in AML for primary induction failure and early relapse population shows that a historical benchmark for response with current treatments for this population is 12.5%. which is a patient population with very dismal prognosis. So in conclusion, consistent with Flotetuzumab's proposed mechanism of action, this data highlights a dynamic induction of an increase in T-cell infiltration and clustering by around CD123 AML cells in the bone marrow microenvironment of AML patients that respond to treatment. The geomics DSP analysis identifies that these T-cell activation or T-cell clusters show T-cell activation markers with increased expression of T activation markers, including PD-1, PD-L2. Flotetuzumab treatment in AML showed a manageable safety profile. Leading dose strategies and early tocilizumab usage have helped to blunt the severity of CRS. The interferon-related gene signature in baseline bone marrows was associated with resistance to cytotoxic chemotherapy, but a response to Flotetuzumab, which leads to defining the target population as the primary induction failure population, which is a high unmet need. In that population, the historical data indicates the best response to salvage therapy of 12.5%, but a clinical response to Flotetuzumab approximating 30% in these heavily pretreated patients who failed AML prior therapies. Overall, I want to acknowledge, and we're grateful for the patients and their families who participated in the study, and I'm very grateful for great collaborators, including Sergio Rutella from Nottingham Trent University, Sarah Church and the team at NanoString, and Bernie Fox and his team at the Earl Childs Research Institute. Of course, the team of Macrogenics is a fantastic team, and we're grateful for the clinical trial teams and all this at the study centers. Thank you very much.
So, Dr. Davidson, I had a few questions. One is the following. If I follow correctly, refractory AML provides an immune landscape that is favorable to this particular drug. My question is this environment intrinsic to a particular AML subtype, or is it a consequence of prior lines of therapy?
Okay, thank you very much for that question. It's an interesting question. What we do know at this point is that this immune inflamed environment seems to be intrinsic to particularly to AML as a whole. What we have done is we've looked at de novo AML patients who can be segregated into these two clusters. We have not seen this associated with any particular AML subtype, except for the fact that P53, we just recently, Sergio Rutella presented some data showing that P53 AML is associated with increased immune infiltration in the tumor microenvironment. This does not seem to be a consequence of prior lines of therapy.
Another question to ask is, can different chemotherapies or treatments provide an optimal TME for Flotetuzumab?
We don't believe that different chemotherapies can affect the tumor microenvironment. At least we have not seen that in our studies. What we have seen is that hypomethylating agents can modify the tumor microenvironment. Namely, more than 3 cycles of hypomethylating therapy in our patients has been associated with increased expression of PD-L1 and other checkpoints, hence potentially obviating the response that Flotetuzumab, the anti-leukemic response that Flotetuzumab could induce.
And finally, one particular question also that I wanted to ask is, what has been the key to ensuring safety profile for this particular drug when other drugs that target also CD123 and CD3 bispecific antibodies have stalled? Also, didn't CD123 CAR T cells fail due to safety? So, in other words, what is critical here about this drug compared to previous experiments?
Safety profile in Flotetuzumab has been, the drug has been manageable. We believe that one of the effects that has helped us in try to control toxicity with Flotetuzumab is the fact that the molecule is, the half-life of the molecule is very short. Hence, a lot of the toxicities that has been noted with other CD123 targeting reagents, as well as CD123 CAR T cells, can be mediated in part by the dosing strategy that we've implemented, as well as Tosilisma, but also by the fact that some reduction in dosing during an acute event quickly leads to resolution of that event because of the half-life of the drug. So at this point, we don't have a particular threshold that is associated with a threshold in inflammation that is associated with Flotetuzumab. We are further exploring this. The idea would be to try to define a predictive biomarker or selection biomarker that we can potentially select patients by using that. And we are definitely looking at using markers in the peripheral blood that could be used instead of relying on more invasive bone marrow biopsies to identify the patients. Overall, we find that Flotetuzumab is associated with responses in patients with immune infiltration in the tumor microenvironment. These patients usually are associated with cytotoxic or with resistance to cytotoxic chemotherapy, and hence identifies a population with high unmet need that can be treated with Flotetuzumab. Thank you very much for allowing me to share our data.